In the United States, you're supposed to show your conflicts of interest before you talk. So these are my important conflicts of interest. This is my family. These are my unimportant conflicts of interest. I have a few patents that the University of Pittsburgh owns. I've been a consultant to several companies, and I have about 4 NIH grants. Okay, monitoring. There's a fundamental monitoring truth, and that is that no monitoring device, no matter how accurate or insightful its data, will improve outcomes unless coupled to a treatment which itself improves outcome. And thus it really doesn't matter what you're monitoring if you're not going to be using it to manage the patient differently. There was a very nice study that was done, organized through the University of Pittsburgh, but a large multi-center study called Process, in which the investigators compared early goal-directed therapy with EGDT, with protocolized care that didn't require blood, or just having the intensivist see the patient in the emergency department if they came in septic shock, and to manage them. And what that study, published in the New England Journal, showed was that it didn't matter which specific process you used, the outcomes were the same. And if you looked at the monitoring that was used, for example, on the top, the amount of central venous catheter was high in the early goal-directed therapy group, but only about half the patients in the other 2 groups that weren't required to put in a central venous line put it in. So those data do not tell you don't put in a central line. Those data tell you that if you want to put in a central line to monitor or to infuse fluids, please do so, but don't do it because I told you, do it because you think it's the right thing to do. You probably do not need to measure central venous O2 sat, because if you look at the amount of fluids that were given in the 3 groups, they were almost identical. Furthermore, in the ARISE study from Australia, they found the exact same thing. We do not need to have a very defined protocol or monitoring. What we need is an intelligent physician at the bedside understanding the physiology, which is what I'm going to show you in a minute. We can take a certain degree of comfort and pride in being critical care doctors, because when the group in Australia reviewed the overall, the entire Australia-New Zealand area over a period of 12 years, they found that the mortality from septic shock as a group decreased from 35% down to 18% in 2012. And during that same time interval, no new treatment was introduced. We already had low tidal volume ventilation. We already had hemorrhage restriction in terms of giving blood. So what you're seeing here is that just by being a good doctor at the bedside, you can do well. But we can do better. So when we have our treatment priorities, there is a mantra that we should be saying, and that is that we want our monitoring to be continuous, because the dynamic changes in the physiology that we see in our patients probably tell us more than the individual static variables. And you heard a lecture earlier about in the operating room measuring cardiac output, and I agree. You also should measure blood pressure. Second, to the extent that you can be non-invasive and still get the data, be non-invasive. If you need to put in a minimally invasive catheter, such as an arterial catheter, that's fine, but to the extent that you can make it non-invasive will minimize the complications. And finally, what you care about is tissue wellness. You really don't care what the cardiac output is. What you care about is tissue wellness. We cannot measure tissue wellness, so we measure surrogates of it. And for that, we would measure oxygen consumption, lactates, metabolic acidosis. So you look at metabolic function. So the functional questions that you ask when you're resuscitating an unstable patient, the very first one is my patient in compensated shock, because at that point in time, they don't have organ ischemia. If you think they have a low output and causing ischemia, the next question you would ask is, okay, if I give them volume, will cardiac output go up? Yes or no? Because if it will not go up, I shouldn't give them volume. Third, is the arterial tone increased, decreased, or normal? Because a normal blood pressure doesn't tell me anything. In my second talk tomorrow, I will discuss blood pressure targets. And finally, is the heart able to maintain adequate output under pressure without going into failure? And I submit to you, these are the only questions you really ask from a cardiovascular perspective of your patient. Well, if we focus in on compensated shock and ask, will the cardiac output increase? This is not a minor point, because when you look at postoperative complications, we see that if you under-resuscitate your patient, you have a significantly elevated amount of postoperative complications. But just giving volume until you can give no more is dangerous too, because over-resuscitation causes edema, poor wound healing, and excessive bleeding. That's in the operating room. Regrettably, in the ICU, the stakes are higher. We have less flexibility in terms of hypovolemia and volume overload, and so we have to titrate care much closer. One has to be precise in giving the right amount of fluids. So why don't we just give every single person who comes into the emergency room or from the floor who presents in shock volume? Well, Frederick Macquart and Jean-Louis Touboul looked at that, and they asked the question, if you give fluids to patients presenting with shock, either on the floor, in the emergency room, in the intensive care unit, will their cardiac output go up, yes or no? If the cardiac output goes up, they call them responders. The cardiac output did not go up, they call them non-responders. I'm actually an author on a few of these papers. I have no idea why that's there. There it goes. What they found was that 50% of all the patients who present in shock are not volume responders. Now, if you're a baseball player and you have a batting average of 500, that's pretty good. But if you're a doctor and you have a batting average of 500, that's pretty bad, because it means you're delaying the right treatment half the time. And if they're volume overloaded or in pulmonary edema, you may make them even worse. So what we assume is that venous return to the heart and right ventricular preload are the primary determinants of cardiac output, and we evoke Starling's law of the heart. And we assume if we have a small left ventricular end diastolic volume, we're volume responsive. And so we measure surrogates of preload. Those surrogates of preload have no relationship to volume responsiveness. This is just one example that shows there's no relationship between the change in CVP, or pulmonary artery occlusion pressure, and the change in stroke volume with fluid loading. Kamar went even further in their patients with shock. They could not find a single relationship between right ventricular filling pressures, here shown as CVP, and right ventricular end diastolic volume, or their change, or left-sided filling pressures, wedge pressure, and left ventricular pressure, or its change. And if you ignore the end diastolic volume, just say stroke volume. There was no relationship either. So if you learn nothing from this talk up until now, please learn this. Preload is not preload responsiveness. I can have a big ventricle and be volume responsive. I can have a small ventricle and not be volume responsive. The most common form of heart failure today is diastolic dysfunction. That's heart failure with preserved ejection fraction. And that shouldn't surprise you, because we've known that for over 100 years. Starling and ANRAP worked together in London after ANRAP moved to London from St. Petersburg, where he was working with Pavlov, the great Russian physiologist. What they showed was that, in fact, the heart has two responses. What we see in this human heart from a paper in 1959 is that here is your end-diastolic volume, and this is an isolated perfused human heart, and you can see that this is your stroke volume. The heart gets smaller. All these investigators did to this viable heart is simply increase the amount of volume coming into it. And you can see the Starling mechanism beautifully occur. Note that as the end-diastolic volume increases, the stroke volume immediately goes up. That is Starling's law of the heart. But look, over time, the volumes in the ventricle decrease, and in fact, the stroke volume stays high, and the filling pressures are actually lower than they were before, because what has happened is you've increased intrinsic contractility. That's what all your patients, except the ones with severe heart failure, do. In fact, the American Heart Association defines heart failure as those patients who need to use the Starling mechanism to sustain an increase in stroke volume. Okay? So I would never expect preload to respond to be preload responsiveness. But think for a second. With breathing, I change preload all the time, and I can use dynamic changes in preload to assess volume responsiveness. And to do that, I use heart-lung interactions. Since the heart is in the chest, increases and decreases in intrathoracic pressure will affect the pressure gradient for venous return to the heart, independent of the heart itself. And as I showed in 1984, with positive pressure breathing, the CVP rises, impeding venous return, right ventricular filling pressure falls, and right ventricular stroke volume goes down. And with Andre Deneau, we went into the operating room, and using transesophageal echo and automated border algorithm, we could measure left ventricular areas. And you can see that after a couple of beats, that decrease in right ventricular stroke volume causes a decrease in left ventricular end-diastolic volume, and therefore stroke volume. So whether you like it or not, a positive pressure breath is going to alter preload beat to beat, and you can use the Starling mechanism to look at them because that's an instantaneous change. So I can have a good heart or a not so good heart, and if they're underfilled, I will see that the stroke volume will vary in both ventricles. If I fill them more, the not so good heart won't vary much. The good heart will still have a response. Eventually all hearts become non-volume responsive. So in collaboration with Jose Marquez, we went into the operating room, put an aorta, a flow probe on the aorta, and measured arterial pressure and did an IVC occlusion in human beings. This was the first time this had ever been done in humans. It took us 3 years to recruit 6 patients. And you cannot believe the consent form that we had to do this study. But we had, for the first time ever, real physiologic data in human beings. Here is the aortic flow, and here is the arterial pressure. And when you plot stroke volume versus arterial pressure over the physiologic range, they are linearly related. And I can measure pulse pressure on anyone. It's very easy to measure. And so in collaboration with Jean-Louis Thibault and Frederick Macard, who was our fellow at the time, we quantified the changes in pulse pressure, not the systolic pressure variation, which is pulsus paradoxus, but the pulse pressure variation. And we showed that the greater your pulse pressure variation, the more your cardiac output would decrease if you were given PEEP. And furthermore, on PEEP, if you gave volume, if you had a high pulse pressure variation to begin with, you had a higher cardiac output. We then showed the exact same thing in patients with severe septic shock. The greater your pulse pressure variation on positive pressure breathing in septic shock, the higher your cardiac output. And furthermore, when you then gave fluid to the patient, if their cardiac output went up, their pulse pressure variation went down. And it doesn't matter what? Oh, I'm going to be a little bit. Okay, it doesn't matter if you measure platysmograph, it works. You can use aortic flow velocity, that works just fine. All these methods work. You can go to the right side of the heart, as Antoine Villard-Baron did, and look at superior vena cava collapse, it's accurate. You can look at inferior vena cava collapse, it's not as good. Or what the group of Philippe Vignon, Michel Salama, who was just here this morning, and Antoine Villard-Brown did, is they went into 8 ICUs and looked at every critically ill person, whether they had heart failure, tamponade, pulmonary hypertension, shock of any form, and they found that all the measures of pulse pressure variation and changes in velocity of the aorta and SVC volume change, diameter changes, predicted volume responsiveness. We propose, why don't you just look at the internal jugular vein, because you image it anyway when you're putting in a central line. And if there's a variability, as you can see here, you're volume responsive. If there's no variability, you're not. And when you combined it with pulse pressure variation, so you're looking at both the right and the left side of the heart, it's near perfect. If you are breathing spontaneously, you can just do a passive leg raising test. And when we examine that with Xavier Monet, you can see here's the esophageal Doppler of a spontaneously breathing person. As we gave, I don't know what's going on up here. Okay. That's the passive leg raise. That's the response to volume. If you had no change in cardiac output with passive leg raising, you didn't have a change with volume, and you can measure it with a totally non-invasive vascular impedance method as well. It works, and the data shows that's kind as well. So what we suggest is that if you are breathing spontaneously, you either do a passive leg raise and look at the change in cardiac output or give volume. So what values should we look at? Well, in an ideal world, we say a threshold value of about 15%. If you're below that, you're not volume responsive. If you're above it, you are. But that's not the way the world works. If you're worried about volume overload, you might give a higher threshold. And if you're really worried and want to give more fluids, you might make it lower. And I would say to you that in terms of the monitoring devices that we have available today, both non-invasive shown at the top, down to arterial, the totally, completely invasive, I am sure that you already have at least one of these devices in your hospital right now. You don't need to buy another device. You have everything. And the magic numbers are during positive pressure breathing, about 10 to 13%, which means if you can see a pulse pressure variation on the screen, you're volume responsive. But if you're just looking at the change in cardiac output, you need to measure it with a continuous cardiac output monitor, and the threshold value is 10%. And based on that, you can actually individualize the management of your patient. And I would just show quickly, I'm going to skip this because there's no time, that by personalizing it, by doing a stroke volume minimization, they could decrease the amount of time in the operating room on mechanical ventilation, ICU stay, and hospital stay. They could, by using this pulse pressure variation analysis, have less intraoperative hypotensive episodes and post-op complications. When they looked at lactate levels using this, the lactate levels in blue were lower if you were in protocolized care. And even for the same blood pressure, if you use the same protocolized care, the control group that didn't use stroke volume variation had higher complications. Most of the complications, however, were seen in the bowel surgery, which is known to be dangerous if you have ischemia or overhydration, both of which you want to avoid. And using pulse pressure variation or stroke volume variation, you minimized it. What this study showed, which was very nice, is you gave more volume early and less volume late in the post-op, and this time in the hospital was less. And by meta-analysis, even compared to the best we do now, if you do volume resuscitation based on pulse pressure or stroke volume variation to determine volume responsiveness, you decrease mortality and length of stay. So in conclusion, functional hemodynamic monitoring guided resuscitation will avoid giving fluids in a non-fluid responsive patient, allow personalized fluid and vasopressor resuscitation, and decrease ICU time and untoward events. I'm not going to go through the protocol, but it's published. And it's the one that's being used routinely now in 3 multi-center trials throughout Europe. And with that, I thank you for your attention.